Very few of us go through even a week of our lives without experiencing anxiety or fear. In this lecture, we focus on a group of disorders called anxiety disorders. Both anxiety and fear play a significant role, so it's important to understand some of the differences between these two emotions. We'll look at that a little later in this lecture. This week, we study the major anxiety disorders included in DSM-5: specific phobias, social anxiety disorder, panic disorder, agoraphobia, and generalized anxiety disorder. Obsessive compulsive disorder and trauma-related disorders share a good deal in common with the anxiety disorders, but are also distinct in some important ways. To recognize those distinctions, the DSM-5 places these conditions in new chapters next to anxiety disorders, and we will cover obsessive compulsive and trauma-related disorders in this course. As a group, anxiety disorders are very costly to society and to people with the disorders. These disorders are associated with twice the average rate of medical costs, a higher risk of cardiovascular disease and other medical conditions, twice the risk of suicidal ideation and attempts compared to people without a psychiatric diagnosis, difficulties in employment, and serious interpersonal concerns. There's a lot of overlap in the way the various anxiety disorders are defined. All share excessively high or frequent anxiety. The overlap of symptoms means a differential diagnostic process is especially important. Carefully studying the clinical cases in John Barnhill's book in Chapter 5 will help you develop skills to differentiate among these disorders. The DSM-5 Handbook of Differential Diagnosis by Michael First includes a chapter entitled Differential Diagnosis by the Trees. This involves the use of decision trees to reach an appropriate diagnosis. This text wasn't required for this course, but you may want to consider getting it just to keep in your library. Differential diagnosis is the process of going from the client's chief complaint to the actual diagnosis. Decision trees are tools which help avoid premature closure or coming to a conclusion about a diagnosis too quickly based on thinking that the client reminds you of another client that you've seen previously. Michael First notes that the gateway to all treatment is diagnosis. Sometimes treatment doesn't work because the treatment is ineffective, but sometimes it's due to a premature and incorrect diagnosis. Here I've provided an example of a decision tree for the differential diagnosis of anxiety disorders. Of course, they start with significant anxiety-related symptoms and impaired function. Then you want to focus on the predominant symptom. If there's a trauma history and flashbacks are reported, you would check for PTSD. If obsessions and compulsions are present, check for obsessive-compulsive disorder. If there is uncontrollable worry about several areas, check for generalized anxiety disorder. A fear of social scrutiny, which is accompanied by intermittent panic, anxiety, and avoidance, would result in considering social anxiety disorder. If there is anxiety and avoidance of discrete objects or situations, check for a specific phobia. And if some of the panic and anxiety attacks are uncued and spontaneous, check for panic disorder.
Now, anxiety disorders differ from normal feelings of nervousness, which we all have. Untreated anxiety disorders can push people into avoiding situations that trigger or worsen their symptoms. People with anxiety disorders are likely to suffer from depression as well, and they may also abuse alcohol and other drugs in an effort to gain relief from their symptoms. Job performance, schoolwork, and personal relationships can also suffer. The central defining feature of anxiety disorders is the experience of a chronic and intense feeling of anxiety. The sense of dread about what might happen to you in the future. This anxiety causes people to have great difficulty functioning on a day-to-day basis. People diagnosed with anxiety disorders experience fear, which is the emotional response to a perceived or real imminent threat. The DSM-5 provides clarification, at least in a clinical sense, about what we mean when we use the words fear versus anxiety. Fear is the emotional aspect. Anxiety, on the other hand, is the cognitive component, which is then accompanied by physiological and emotional reactions. People cope with fear and anxiety in various ways. Sometimes the level of fear or anxiety is reduced by pervasive avoidance behaviors. Now, they are pervasive because they infiltrate important areas of functioning. For example, in social anxiety disorder, individuals may avoid or seriously minimize contact with other people. At home, they may not answer the door. At work, they may miss or skip meetings or keep their office door closed. These types of situations that are feared or avoided and the cognitive aspects associated with them help the clinician to differentiate among the anxiety disorders. For example, in specific phobias, the fear is focused on an object or a certain situation, perhaps spiders or riding in an elevator. In generalized anxiety disorder, the fear and anxiety are free-floating and they cut across various areas of life. Panic attacks are a symptom and a prominent feature of anxiety disorders. Now, as a symptom, panic attacks may be seen in other mental disorders. I just want to clarify here that panic attacks do not appear in all anxiety disorders, and there are individual differences. People with anxiety disorders have difficulty engaging in adaptive behaviors to manage the fear. Think of a time you felt anxious or fearful. The first day of college or the first day on a new job. The chances are you responded in an adaptive fashion. That is, you handled the perceived threat or new situation through an appropriate response. You went to school or work and made an effort to meet new people. Adaptive fear responses subside when the threat or perceived threat is ended. Maladaptive anxiety persists after the threat passes and can even lead to anticipatory anxiety about the future. Other people in the situations I just mentioned might have had unrealistic fears, so that they responded in a way that was maladaptive. They didn't go to class, or they stopped going to work. With maladaptive anxiety, people behave in ways that lead to impairment. As with all mental disorders, the biological dimension shouldn't be overlooked. Some medical conditions may be confused with anxiety disorders. Diabetes, for example, has been linked to some symptoms of anxiety. Also, just having a medical diagnosis may be psychologically stressful and anxiety producing. Some other medical causes include hyperthyroidism and cardiac arrhythmias. Some asthma medications may induce symptoms of anxiety, as well as some stimulants that may have been prescribed. Withdrawal from alcohol also needs to be considered. The withdrawal syndrome from addictive drugs, including alcohol, is the opposite of the drug's effects. Alcohol is a depressant, so the withdrawal syndrome would be characterized by anxiety. To understand the biological dimension, it's also necessary to understand the fear circuitry in the brain. The amygdala is the part of the brain that stores our emotional memories, especially those associated with danger. When we encounter a situation that is potentially threatening or associated with a threatening event from the past, the reaction activates two separate neural circuits, the HPA axis and the amygdala's connections to the hippocampus and prefrontal cortex. The HPA axis is activated quickly and automatically. This is our fight or flight response. The fight or flight response is responsible for physiological changes that occur when there is an actual or perceived threat. With anxiety disorders, it is in overdrive because it's activated too often. Now, when the HPA axis is dysregulated, as in many anxiety disorders, the fight or flight system doesn't turn off. The secondary fear circuit is slower, but it involves higher level processing, which can shut off the HPA axis if it determines that no threat really exists. If the person can engage in effective reappraisal of the situation, then anxiety would be reduced and an adaptive response could occur. Phobias are sometimes due to associations created by classical conditioning. Childhood fears can be triggered in adults simply by sounds, smells, and even words that bring up memories through the amygdala. The psychological dimension can give us insight as well into the development of anxiety disorders. There is a connection between the mind and the body, and someone's psychological characteristics can interact with biological factors and predispositions. Let's say someone was born with a highly sensitive fight or flight system, or with anxiety sensitivity, which is a tendency to interpret physiological changes in the body as signs of danger. This can leave them vulnerable to developing anxiety. Perhaps someone has a tendency to interpret events negatively and has difficulty seeing the bright side. It's as if they have a mental filter that only lets negativity get through, so they only see how things might turn out badly. Consequently, the future is a threatening place. Through the skill of reappraisal, which can be learned and developed in treatment, they can realize there are alternative perspectives and see the silver linings in even the darkest clouds. Being able to reappraise or reframe in a more positive way can reduce anxiety. And let's not forget the social and sociocultural dimensions. We live in a fast-paced society which places a lot of demands on our time. In fact, a recent survey by the American Psychological Association found that 70% of Americans report their levels of stress are unhealthy. Daily environmental stress can produce anxiety, and people with biological or psychological vulnerabilities are most likely to be affected. Some environmental factors to consider are poverty, traumatic events, adverse working conditions, limited social support, and acculturation. And culture can influence how anxiety is expressed. Some cultures express more somatic or bodily symptoms in anxiety, and clinicians must carefully assess and interpret symptoms of anxiety. A culture may have its own set of rules for talking about emotional experiences. Some cultures see mental health problems as social problems. Individuals in collectivistic cultures may hide or minimize their emotional experiences with social anxiety and express them as more socially acceptable somatic complaints to prevent embarrassment. Now let's start looking at the specific diagnoses, starting with phobias. They're characterized by strong, persistent, unwarranted fears of a specific object or situation. There's extreme anxiety or panic expressed when the phobic stimulus is encountered. And most adults recognize the fear is excessive, but children may not. Phobias are the most common mental disorder in the United States, and the text lists three categories of phobias: social anxiety disorder, specific phobias, and agoraphobia. The characteristic of social anxiety disorder is marked or intense fear or anxiety of social situations in which the individual may be scrutinized by others. There is an intense fear of doing something embarrassing or humiliating in the presence of others. Some people only experience symptoms when they are in a performance situation, but symptoms can occur in ordinary social settings, and this is much more than just shyness. Now, if the fear is restricted to public speaking, the DSM-5 provides a specifier, performance only, to be used. Essentially, the anxiety is centered on a desire to avoid humiliation and embarrassment. For some, even the simple act of drinking water or eating in public can be embarrassing. The fear or anxiety is out of proportion to the actual threat posed by the social situation. The fear and avoidance are persistent and they last for 6 months or more. Often, social anxiety disorder is comorbid with major depressive disorder and substance use disorders, as individuals may try to self-medicate. Women are twice as likely as men to have social anxiety disorder, and this condition can be chronic and disabling. A specific phobia is extreme fear of a specific object or situation. Exposure to the stimulus nearly always produces intense anxiety or a panic attack. This object or situation is actively avoided or endured with intense fear or anxiety. The avoidance reinforces the fear, and it is persistent, lasting for 6 months or more. It's common for individuals to have multiple specific phobias. According to the DSM-5, 75% fear more than one object or situation. Although the prevalence is low in older populations, it is one of the more common disorders in later life and tends to be related to concerns over medical conditions. People with specific phobias are up to 60% more likely to attempt suicide than individuals without the diagnosis, but this may be due to comorbidity with other disorders. Treatment from a biological perspective focuses on symptom management. Consequently, anti-anxiety medications are prescribed. Interestingly, research has shown that different phobias show different patterns of brain activation. The primary types are of living creatures such as dogs, cats, elephants, insects, and spiders. Environmental conditions such as heights, storms, or water. Blood injection or injury, for example, needles or invasive medical procedures, and situational factors such as airplanes or flying or being in an elevator. Some other situations are listed and possible factors for specific phobias in the DSM-5, such as loud noises or costumed characters, such as clowns. In the third category of phobias is agoraphobia. Agoraphobia comes from the Greek word meaning fear of the marketplace. There is intense fear of at least two of the following: being outside of the home alone, traveling via public transportation, being in open spaces, being in stores or theaters, or standing in line, or being in a crowd. These situations are feared because escape or help may not be readily available. There are concerns over the possibility of fainting or losing control over bodily functions. Or for some, the fear involves concerns over the possibility of having a panic attack. About a third to a half of people diagnosed with panic disorder develop agoraphobia. People with agoraphobia reach the point where they never leave home. They're not afraid of situations themselves, like in the specific phobias, but they fear they can't get help or escape if they have panic-like symptoms. Another diagnosable anxiety disorder is panic disorder, which involves recurrent unexpected panic attacks. This is combined with apprehension about having another attack or behavioral changes designed to avoid having another attack. The reactions are present for 1 month or more. People with panic disorder experience periods of intense physical discomfort known as panic attacks. During a panic attack, people may feel like they're going crazy, losing control, or that they're going to die. There's a sense of impending doom. Now, having an occasional panic attack is not enough for a diagnosis. They have to happen more than once. And there has to be evidence of fear of having another attack and maladaptive behaviors to avoid another attack. It is this fear or avoidance that distinguishes panic disorders from other disorders that may involve panic attacks. Some of the symptoms of panic attacks are palpitations, sweating, shortness of breath, feeling like you're choking, chest pain or discomfort, feeling dizzy or feeling nauseous. The 12-month prevalence rate for panic disorder in the U.S. is 2.7%, and it's twice as common in women as in men. Now, treatment can involve imipramine, which is a tricyclic, one of the older antidepressants, which can reduce panic attacks in the majority of cases. SSRIs are also effective. Clients are taught relaxation techniques and breathing exercises, which give a sense of control and help clients to ride out the wave, if you will, and learn that the attack will pass and that they won't die. These relaxation techniques help to calm the HPA circuit and stop the fight or flight response. Cognitive behavioral treatments teach clients to recognize catastrophic thoughts and reframe to reinterpret their bodily sensations. People diagnosed with panic disorder tend to interpret bodily sensations in a very negative way. Cognitive behavioral therapy is very effective in treating panic disorder as it increases self-efficacy and a sense of control over one's body. It teaches coping statements to address catastrophic thoughts like, I am dying, I'm losing control, I am going crazy, whenever there's a perception of unpleasant bodily sensations. This way, clients can stop the negative cycle, which is shown here, which can make panic attacks worse. Some people are anxious all the time, in most situations. People diagnosed with generalized anxiety disorder worry about many things in their lives. People with GAD are also tired most of the time. Persistent high levels of anxiety and excessive hard-to-control worry over life circumstances characterize GAD. The DSM-5 diagnostic criteria include that symptoms must be present on the majority of days for 6 months, and these symptoms cause significant impairment in life activities. This disorder tends to develop gradually and often begins in childhood or adolescence. Many people with GAD report they have felt anxious and nervous most of their lives. This excessive worrying makes it difficult for them to do things quickly and efficiently. These individuals are focused on potential threats, and you may hear something from them like this: it's always best to expect the worst. They believe worrying can help them avoid bad events, but this worrying keeps them from engaging in active problem solving. Psychologists have shown that people with GAD focus on potential threats, and they've done this through the use of the Stroop color naming task. In this task, words are flashed on a computer screen for a brief period of time, and the person is asked to name the color of the word. People with generalized anxiety disorder are slower to name the color of the words with threatening content compared to neutral words, presumably because they are attending to the content of the threatening words. And here's what it looks like. A card would be flashed, and the correct answer would be red. Another card would be flashed, and of course the correct answer here is green. What psychologists found was it took longer for those diagnosed with GAD to name the color of the cards with words like disease compared to neutrally worded cards.
I mentioned in a previous lecture that with the increase in diagnostic categories, normality is becoming an endangered species. In this brave new world of psychiatric overdiagnosis, you wonder if anyone will get through life without a mental disorder. The National Institute of Mental Health estimates that in any given year, 25% of the population has a diagnosable mental disorder. That's almost 60 million people. One study found that by the age of 32, 50% of the general population will have qualified for an anxiety disorder. Dr. Alan Francis cautions that the DSM-5 definition of generalized anxiety disorder is too loose and recommends that the diagnosis be reserved for worries that are clearly beyond the ordinary, resulting in a pervasive effect on daily functioning. We live in a society that is perfectionistic in its expectations, and a society that is intolerant of what were previously considered to be normal and expectable distress and individual differences. As a group, anxiety disorders are the most common type of mental disorders. The specific anxiety disorders are each defined by a different type of key symptom. People with one anxiety disorder are very likely to experience a second anxiety disorder during their lifetime. About 60% of people with anxiety disorders will experience an episode of major depression during their life. Women are much more likely than men to report an anxiety disorder, and culture influences the focus of fears, the ways that symptoms are expressed, and even the prevalence of different anxiety disorders. I'm highlighting on this screen the screening questions that are identified by Dr. Francis to help you pin down the specific type of anxiety disorder that is being presented during your diagnostic assessment.